Hi YouTube, this is the IHF team. We are a medical scientist, an engineer, and a healthcare technologist. Welcome to our channel. The Immunohematology Framework, IHF, a universal operating model for the blood transfusion domain. This is the next video in the IHF series. Current challenges and donor selection practice. Presentation topics. In section 1 of this video, we will be discussing current blood transfusion domain challenges. Section 2 examines the current practice of patient donor selection. We conclude with how the IHF approach solves for these issues, inefficiencies, and gaps.
Hi, this is Elena, Butina. Section 1 contains an overview of some challenges I have faced as an immunohematology practitioner. Overview. As many of us know, blood transfusions are the most frequently performed hospital procedures in the United States, with approximately 15 million red blood cell (RBC) units being utilized annually, and an estimated 85 million blood transfusions are performed worldwide each year. There is a huge assortment of information that is accumulated in electronic medical records, laboratory information systems, patient databases, and donor registries. Medical researchers and physicians are faced with so much information of high complexity that oftentimes they are unable to adequately process it. Donor selection practice complexities. All transfusion patients require an adequate immunohematological evaluation so that the blood products they receive meet clinical guidelines and standard operating procedures. In more complex donor-recipient situations, additional clinical parameters and multifactorial immunohematological markers must be considered, which significantly adds to the difficulty of the medical decision-making process. Today's physicians are forced to rely on their own knowledge and experience, which can lead to poor patient outcomes. We know that recipient alloimmunization is associated with a risk of hemolytic transfusion reaction or hemolytic disease of the fetus and newborn. This brings us to the topic of RBC selection practice complexities. The current selection practice poses significant challenges for the effective prevention of patient alloimmunization. Coping with large amounts of data and the existing standard methods of selecting RBCs that have a desirable repertoire of antigens is time-consuming and resource-intensive. This selection practice has become even more difficult due to an increased demand for extended phenotype matching. Further, finding suitable blood products for recipients who lack common antigens, possess uncommon antigens antigenic combinations, or have antibodies to common antigens magnifies this challenge. Another challenge is RBC cryopreservation, which is an expensive procedure. Let's discuss this need. Cryopreserved RBCs are called upon when fresh RBCs with the required phenotypes are unavailable in the blood bank or when there is insufficient time to recruit compatible donors. Such situations tend to occur when a potential recipient has a rare blood type whose phenotype lacks any common antigen-antigenic combinations. Or it could be that the would-be recipient has antibodies to antigens that are usually present in the general population. Or in a case when an extended phenotype matching selection is required for a patient with alloantibodies or autoantibodies. Is it difficult to manage a blood bank long-term inventory? The answer is yes. A cryopreserved RBC pool is difficult to curate. The proper management of such a reserve is fraught with difficulty. While refrigerated RBCs with phenotypes compatible with a large number of recipients are always in high demand, there are certain phenotypes that are rarely needed, except for the complex recipient, whose blood type may be rejected for inclusion into the reserve because of lack of demand. Let's point out that the empirical stocking of long-term inventory with cryopreserved units typically leads to the accumulation of RBCs whose phenotypes are widespread in the population, a mirror of what is already available in refrigerated form. Another ongoing challenge is to optimize blood bank inventory distribution amongst recipients, especially when multiple requests have to be fulfilled at the same time. The next topic is collection and distribution, maintaining balance. The art of managing blood supplies requires maintaining a proper balance between the collection and distribution of blood components. distributing RBCs amongst patients so that each of them receives the required level of compatibility with minimalization of wasted product calls for sophisticated unit selection methods. The greater the number of donor and recipient antigens, to compare the greater the difficulty of making the proper decision becomes. Absence of fully compatible blood, RBC selection challenge. Another blood banking challenge is how to select red blood cells when fully compatible blood is not available. In situations when fully compatible blood units are not available, or when there are time constraints that delay obtaining a fully compatible donation, physicians are compelled to select from RBCs that are only partially compatible with those of the recipient. As practitioners know, it is difficult to choose the least immunologically dangerous RBC phenotypes from incompatible ones. Currently, this selection process is performed by a clinician who is dependent on their thought processes to assess the level of immunogenicity and clinical significance of various antigens. As a result, an improper selection may cause alloimmunization of the patient, which can lead to serious problems that may require additional transfusions while taxing care resources and increasing the probability of future HTR.
Hi, this is Gennady. As an engineer, I always identify the source of a problem. What are the root causes of blood banking domain issues? Here are a few examples. The operating models that currently support patient blood unit selection have substantial limitations and drawbacks. Existing operating procedures do not support efficient long-term blood bank inventory management. We conclude that at the present time, a comprehensive approach capable of addressing these challenges does not exist.
This is Elena. This next section defines the current recipient-donor matching practice. It also briefly describes RBC selection issues and inefficiencies that we face as immunohematologists. Of course, we are going to begin with ABO and RHD. It is universally accepted that it is best to perform a blood component transfusion when the donor is identical to the recipient in the ABO system. On those occasions when such a blood type is not available, RBCs that are compatible with antibodies present in the recipient can be substituted. In those patients who are not alloimmunized, the standards put forth by the AABB do not require the routine selection of blood components for antigens other than ABO and RHD. The next step is RH and KEL donor selection. Blood banks go beyond ABO and RHD to do their best. They provide patients whose lives depend on transfusion therapy with RH and KEL compatible RBCs. What are the recipient-donor phenotype matching types beyond routine? They are limited and extended. Phenotype matching that goes beyond ABO and RHD is generally applied only to certain high-risk patient groups. Compatibility of donor and recipient phenotypes may be defined by the antigens included in the limited phenotype matching, or it can be extended with the addition of specific antigens of the Duffy, KID, and MNS blood groups. Is there a commonly agreed upon method to perform phenotype matching? The answer is no. As of now, there is no generally agreed method for the comparison of phenotypes, which represents a significant challenge to hospitals and blood services. Is phenotype-based selection the best practice for patient-donor RBC selection? We think so. The fundamental reason for providing recipients with phenotype-matched RBCs relies on the need to prevent alloimmunization and the attendant complication of HTR. Is there disagreement with this approach? Yes. Opponents of phenotype-based selection attempt to justify their opinions by pointing to the difficulties in implementing such a policy in blood banks and medical centers. They instead advocate for determining donor selection by phenotype only for patients belonging to specific categories. Let's review a few examples of phenotype matching from international practice. In both the United States and the United Kingdom, patients with hemoglobinopathies are tested for antigens ABO and RHD, as well as for big C little c, big E little e, and KEL as an integral part of their RBC selection. In the Netherlands, for those patients with autoimmune hemolytic diseases, myelodysplastic syndrome, and clinically significant antibodies, RBC selection is even more extensive, as that nation routinely tests for the Duffy A antigen, and whenever possible, KID B and big S little s antigens. The next problem to highlight is the blood bank's challenge in selecting the proper donors for alloimmunized patients. As it is imperative that alloimmunized patients receive specially selected RBCs, blood banks have the additional responsibility of determining the most suitable donors for this group, and then performing the most appropriate pre-transfusion selection of blood components for them. It is no surprise that these processes are often time-consuming, and so optimally, the high risk of alloimmunization is lessened by typing and selecting phenotypically compatible blood from the very start of the transfusion process. Finally, what factors make RBC selection by phenotype difficult? The selection practices now in use pose a significant challenge to the prevention of the untoward consequences of patient alloimmunization. Currently, to obtain the most preferred repertoire of antigens for a specific patient, large quantities of resources and significant amounts of time are consumed due to the inherent inefficiencies of today's methods. This is becoming even more problematic with the growing trend of ordering extended phenotype matching. Further, finding suitable blood products for recipients lacking common antigens, or for those with either uncommon antigen combinations or antibodies to common antigens, is especially challenging.
Is there a solution to make donor selection more efficient and effective, especially in challenging situations? As an engineer, I can offer a solution. The approach is to develop methods, models, and algorithms that can be implemented via a computer system, one with the ability to account for multifactorial parameters, including demographic, clinical, and laboratory data. A system of this type would assess RBCs both accurately and selectively by matching the phenotypes of blood donors to potential transfusion recipients. And this is the IHF approach.
We hope that you found this video informative. Please subscribe to this channel and watch our other videos, which dive deeper into blood transfusion domain challenges and the IHF solutions that solve them.